Good morning to all the respected chairpersons, faculty and delegates. Greetings from CMC Vellore, India. So after the previous talk, which exhaustively dealt with the pathophysiology, it's on to a much lighter talk, which is a current evidence-based management in IgA nephropathy. No talk in IgA is complete without mentioning John Berger, who was a pathologist who discovered IgA and IgG deficits in the renal tissue of patients with hematuria. So we'll take you through the guideline that we have right now in existence, which is a KDIGO 2021. It is being revised. The new guideline is in the public draft form, and we do not have the final version of the new guideline. So what I will do is take you through the recommendations of 2021 guideline and then look at what has happened since then till now. So in KDIGO 2021, we need to diagnose IgA nephropathy, make sure it is primary IgA nephropathy, rule out all the secondary causes. And once we are definite that's primary, we score the renal biopsy with the MESC score, after which there is a risk stratification. Now the risk stratification is done using an equation called the International IgA Prediction Tool, which is freely available. Now, the traditional risk of progression, the traditional markers still remain the strong contenders for the risk of progression, which are proteinuria, blood pressure, and eGFR, and there's still not been any other marker to replace it. Proteinuria has been shown as the strongest prognostic factor. It has a dose-dependent effect, especially if it is more than 1 gram per day. But in the recent RADAR cohort, the threshold of proteinuria has decreased further, and it is in the range of 0.5 to 0.7 gram per gram. MES score, when combined with the clinical features like eGFR, proteinuria, and blood pressure at biopsy, predicts renal outcome with the same accuracy as clinical data at 2 years of follow-up. So what MES score does it allows you to risk stratify it at an earlier point in time, whereas if you just take the clinical parameters, you to accurately predict, better to wait till 2 years. The International IgA Nephropathy Network equation was published by Barber et al. In 2019, and it's available freely for use. There's currently no other validated biomarkers for the diagnosis or for the prognosis of IgA nephropathy. This is an example of what all variables need to be inputted into that equation. You need to input eGFR, the blood pressures, proteinuria, age, race, whether there's been prior use of RAS inhibitors or immunosuppression, the MES scores, and then you can determine the 50%, predict the 50% decline of eGFR or progression to end stage at a maximum of 36 years after renal biopsy. But somehow in South Asia, this being a cohort that has come from our center, when we looked at the performance of the International IgA Nephropathy equation, we do have a population that has a severe presentation and is at a very high risk of progression. When we looked at its performance with the patients in the x-axis and the International IgA Nephropathy score in the y-axis, the red ones are the patients who had worst outcome at 3 years, and the green ones are the ones who had good outcomes, still were having good outcomes at 3 years. The median score for the International IgA Nephropathy was lower, 18.2, and there were many in the lower group that also progressed to end-stage kidney disease. So the sensitivity and specificity of this equation it still underestimates IgA in our population. So in the algorithm of KDIGO 2021, following risk stratification, The next thing is to optimize the background therapy or the supportive care. And this could mean optimizing blood pressure, increasing RAS blockers to the maximum tolerated dose, lifestyle modification, and address cardiovascular risk. Now, there's no doubt that there's a role for RAS inhibitors in the management of blood pressure. This has been supported by various clinical trials. It doesn't matter whether you're using AC inhibitor or ARB, you can use either, but not in a combined manner. Especially in a large RCT like the STOP IgA, it was seen that after optimization of the background therapy, about 1/3 of the patients were no longer even eligible to get randomized to the immunomodulatory therapy. So KDIGO 2021 is a grade 1B recommendation for the use of RAS inhibitors, especially if it is more than 500 milligram with or without hypertension. The other ways to control blood pressure is to restrict dietary sodium, normalize weight, because obesity has a direct effect on worsening hypertension, the eGFR, as well as in having proteinuria. So need to increase physical activity and smoking cessation. It's been shown that even if there's a 30% reduction of proteinuria at 9 months, there is a 50%, it translates to a 50% lower risk of end-stage kidney disease, and you get an extended time of 11 years, the median time to end-stage kidney disease. The other traditional immunomodulatory agents like fish oil has had conflicting reports and are not, it's not harmful, but even the benefits have not been seen. So it's up to the individual person to whether use it or not. But even if you use it in the full dose. Now coming to those people who have been optimized. So patients after they have been optimized of the background therapy, and if they still remain at high risk of progression, in KDIGO 2021, the high risk is proteinuria more than 1 gram. But as I said, the recent studies like RADA UK have further reduced the threshold of proteinuria for the starting of immunomodulatory therapy. And the first recommendation for such patients to see whether they were eligible to be enrolled in a clinical trial. Now, over the last decade or so, there's been a plethora of clinical trials in IgA nephropathy, the nature of which we have not seen in any of the past generations. This is mainly because there's been a significant regulatory change by the FDA, the NKF, and the EMA bodies, where they now accept a reduction in proteinuria as a reasonable likely surrogate. So if you can measure and show that there is a significant reduction in proteinuria at 9 months, it becomes a reasonably surrogate endpoint for a composite outcome, a worse renal composite outcome, and the companies or the industries are allowed to file for accelerated approval of the new investigational molecules. This further will need to be confirmed by a benefit in the eGFR slope at a time point of 24 to 36 months. And once that happens, then the accelerated approval can be converted to, once you can show a benefit, it can be converted to a complete approval. And because of this, we don't have to wait for patients to reach composite endpoint regarding the chronic progressive nature of IgA. It takes at least 10 to 20 years for patients to reach that composite endpoint. So this has led to a plethora of clinical trials. In the KDIGO guideline, the role for steroids as an immunomodulatory therapy in 2021 guideline was given with much caution, especially recommended only for eGFR more than 30, and the risk and benefit ratio needed to be discussed. This was because the earlier smaller trials in steroids were underpowered, though it did show a legacy effect. The meta-analysis did show reduction in proteinuria, but there was significant risk of adverse event. Two other trials that happened before the KDIGO 2021 guideline was the STOP IgAN trial and the full dose testing study. The STOP IgAN did show a significant endpoint improvement, but again there was no significant difference in the rate of loss of kidney function, and there were more infections in the immunosuppressive group. The testing trial, which aimed to randomize about 1,300 patients, had to have an interim stop after randomizing 262 patients at 1.5 years, because by then it had shown, though it had shown significant improvement in the renal outcome, there were concerns regarding serious adverse events. So till the 2021 guidelines, the evidence we had for steroids was with the Valiga trial telling us that the greatest benefits probably will be in patients who had nephrotic range of proteinuria. STOP IgAN, where because there was persistent proteinuria was excluded, there was, it limited the generalizability of the results, and there was no significant decrease in renal function. And the testing trial where, in spite of renal outcome, there was significant serious infection. And these were the various regimens of steroids that were being followed at that till 2022. So what happened in 2022? The testing trial, after the interim results, they modified the dose and adopted the low dose testing regimen, where the methylprednisolone was given 0.4 milligram per kg per day, a maximum of up to 32 milligram per day, and then weaned by 4 milligram per kg per month. So they randomized 500 odd patients into methylprednisolone and placebo arm, and there was a significant difference in the composite outcome, which was a sustained 40% decrease in EGFR, kidney failure, or death due to kidney disease. The serious infections, there were a few infections, but it was not very significant. And mind you, this protocol required that all patients had to take PCP prophylaxis. So there was a significant improvement in the methylprednisolone arm with regards to all the outcome. The other two immunosuppressive therapies that have been studied are the mycophenolate. Again, mycophenolate, there's no evidence in the non-Chinese population till now. And hydroxychloroquine, again, there is evidence in the East Asian population, but there's been no evidence in the other population. Having said that, there's a clinical trial which has started recruitment in Europe. It is a multi-center trial in France, which is looking at HCQ as a beneficial agent in IgA nephropathy. So there are many new investigational molecules. In my talk, I will just be going through the ones that have received at least accelerated approval in IgA nephropathy. So we have the NephCON. NephCON is the first IgA-specific molecule that has been approved. We have the SGLT2 inhibitors, again approved by the FDA. We have the budesonide, which is a targeted release budesonide. We have LNP023, which is now called the iptacopan. And we have the sparsentan, and all of these have received, iptacopan has received accelerated approval, and sparsentan has received full approval. Now, we are all aware of the SGLT2 trials. There were two landmark trials, the DAPA-CKD and the EMPA kidney trial. In DAPA-CKD trial, they looked at a subpopulation comprising of 270 participants who had IgA nephropathy. The eGFR was between 25 to 75 ml, and the albuminuria was between 200 to 500 milligram per gram. And with dapagliflozin showed significant benefit in composite outcome in this group. Similar results were obtained with empagliflozin. It was probably one of the largest studies done in CKD ever. We had some 3,000 odd patients randomized to placebo as well as to empagliflozin arm. And when they did it, in all subgroups, it showed benefit. regardless of whether there was diabetes or whether there was no diabetes, in all the GFR classes except for those with very low albuminuria. Now, in the secondary analysis of the EMPA kidney trial, when they looked at the different causes for kidney disease, again, a benefit was seen in the glomerular disease category. The next molecule is a NephCON. NephCON is a targeted release budesonide. It has a different, very unique formulation with an enteric coating that causes a delayed release. It has a triple coated beads and a polymer coating which causes a sustained release. Now, this allows a molecule to be released in the distal ileum near the pairs patches. The other molecules got the controlled release formulations of budesonide, which are generically available in many countries. The difference between this molecule and the others that are available in the market are though it is controlled release, they are released throughout the small intestine. And when they have studied the pharmacokinetics of these two molecules, there is significant suppression of serum cortisol compared to NephCON with other controlled release budesonide formulation. So the NephCON trial was a phase 3 trial which proved its benefits with significant reduction. The NephCON was given at 16 milligram once daily for 9 months and compared with placebo. And there was a significant reduction in proteinuria as well as significant benefit in GFR. The common side effects were peripheral edema, hypertension, muscle spasm, acne, and headache. The next molecule is sparsentan. Sparsentan belongs to a very unique class of molecule called DIARA. It is a double endothelin and angiotensin receptor blocker. It blocks ETA receptors and AT1 receptor. It is a non-immunosuppressive renoprotective treatment. And following the success of the phase 2 DUET clinical trial, the phase 3 trial was designed, which is planned for 114 weeks with a double-blind period and followed by an open-label extension. And the interim results of sparsentan did show a significant benefit in proteinuria. And sparsentan has received approval by the FDA. It also shows significant improvement in eGFR compared to placebo. The last molecule that I'll be touching upon will be iptacopan. Iptacopan is a very recent molecule that has received accelerated approval from the FDA. It it blocks factor B in the complement cascade, and so it acts downstream of the pathogenesis of IgA nephropathy. Again, the APPLOS IgAN study, which is a phase 3 multi-center double-blind study comparing iptacopan 200 milligram twice daily with placebo, has shown significant reductions in proteinuria and complement levels in their interim results. So now the supportive care looks something like this. Apart from blood pressure reduction and RAS blockade, we also have SGLT2 now, as well as sparsentan in the algorithm. Fish oil is neither beneficial nor harmful, so up to each individual physician to decide. Tonsillectomy has been shown to be significant in Japanese population, not just a supportive therapy, as you have seen the data previously, that it is also a significant immunomodulatory treatment in the Japanese population. So the current evidence of IgA nephropathy will be a combination of both supportive therapy as well as immunomodulation. Here again, the ones in the green are approved molecules. So you have NephCON, which is acting at the pairs patches and reducing the pathogenic IgA production. You have other APRIL and BAFF inhibitors which are under trial and which will be touched upon by Adrian. We have a general anti-inflammatory molecules which are systemic glucocorticoids. mycophenolate, hydroxychloroquine, and iptacopan, and other specific molecules, which again will be covered in the next talk. And for the supportive therapy, apart from RAS inhibitors, we have two major kits in the block, which is SGLT2 inhibitors and sparsentan. Thank you.
Organizing committee for giving me the opportunity to give this talk. So I'm going to talk on the advances on the treatment of IgA nephropathy, and I'll skip through those that have been covered by the previous two speakers. So these are my disclosure. In addition, I will be talking about novel treatment that has not been approved, and as a member of the KDIGO guideline for GM, I'm going to be talking, making reference to unpublished data from the update of the IgA nephropathy guidelines that was out for public review. So IgA nephropathy is the most common biopsy-proven pattern of injury for glomerulonephritis globally. And if you look at the global distribution of IgA nephropathy, this is a very common disease in the Asian population. And if you look at the way that clinical trials have evolved over the last 2 decades, you'll see that IgA nephropathy, you can't get a trial going without doing the clinical trials in Asia Pacific. And indeed, more than 60% of patients that are contributed to the clinical trials are coming from Asia in recent years. Now, IgA nephropathy, and the main reason why it is important to include Asian patients is because we believe that there is variation in geographical prevalence as well as clinical presentation. We tend to see a lot more aggressive disease in the Asian Pacific region, and really there's really no evidence that IgA nephropathy is a single disease, and in fact, there is going to be a new publication that's coming out from China that demonstrated that the degree of proteinuria as well as the degree of kidney failure progression is actually significantly higher in the Chinese population compared to the Western population. You have heard about the 4-hit hypothesis for the pathogenesis of IgA nephropathy. It begins with hit 1, which is the mainstay of the inciting event, which is increased level of Gd-IgA1 resulting into an autoimmune phenomenon causing production of autoantibodies and then the formation of immune complexes and finally deposition in the glomeruli causing inflammation and fibrosis. Now, we were taught in medical school that IgA used to be considered as a benign condition where many patients just have microscopic hematuria and that it's a slow progressive disease. And that concept has kind of been challenged, and it's because in the beginning, based on the Toronto GN registry, we were taught that we all need to just reduce the proteinuria to less than a gram per day. Now, this has gone much lower based on the UK data that just came out, and this is from the RADAR registry, and they have demonstrated that even if you have proteinuria reduction to less than a gram per day, there is still significant risk of patients going to kidney failure. So if you look at this where they actually moved the proteinuria to less than 0.44, there is still a significant risk of kidney failure within 10 years, about 20% risk, and that if the proteinuria is between 0.44 to 0.88, that risk increased to 30%. And at the same time, if we look at the risk of kidney failure and IgA nephropathy, if you have patients who are diagnosed at an early age, so for example, if you have IgA nephropathy diagnosed at the age of 18, half of the patients will end up with end-stage kidney failure at the age of about 35 years and 30 to 35 years of age. And that's a very significant period in the lives of our patients because it's the most economically productive period, and it's also the time where we'll be starting a family. And so this is a significant concern, and really what we want to do now is not to consider IgA nephropathy as a benign condition, but really to try to bring the risk of end-stage kidney failure to a minimum, such that the patient do not require kidney replacement therapy throughout their whole lifetime. And so in order to do that, this is also an analysis that came out from the RADAR registry. We will need to target that the eGFR decline to be less than 1 ml per minute per year. If anything above a ml, you will notice that a significant proportion of patients will still end up with end-stage kidney disease. and therefore will still need kidney replacement therapy throughout their whole entire life. And so therefore reducing that target to less than 1 ml is the first target that was introduced by the KDIGO guidelines for the 2024 update, and that was put up for public review, and that is one of the target. The second target was to reduce proteinuria to less than 500 milligrams per day, and preferably to less than 0.3 grams per day. So in 2021, we have only corticosteroids. It's like the MCU. We only have the first Avenger, Captain America, and that's the only thing that we have. If you have no idea what this slide means, you need to go and watch some movies. So this is the KDIGO guidelines in 2021. This is the first time an international guideline has recommended that a patient be enrolled into a clinical trial even before the consideration of corticosteroids. And the main reason is that the data for corticosteroids, as Suceena had mentioned, was very conflicting. There was significant side effect, and therefore, because of the scarcity of a treatment option, we actually recommended that patients be enrolled in a clinical trial. Moving forward, 2024, this is no longer the only Avenger that we have. We now have moved into an era of the Infinity War and an Endgame, and we're truly seeing a lot more Avengers coming out for the treatment of IgA nephropathy, and I would dare say that we are actually reaching the Endgame for the management of patients with IgA nephropathy. And this, as Suceena have demonstrated over the last 3 years, we have a huge number of clinical trials that any new drug that comes out, they all want to test it in IgA nephropathy. And so therefore, in 2024, the update that was put up for public review, we now have at least 3 drugs that was approved, at least 2 drugs that's been approved for the treatment of IgA nephropathy, and we have a lot more data to substantiate the use of systemic corticosteroids. So I'm going to approach the emerging treatment based on the pathogenesis of IgA nephropathy, you know, the 4-hit hypothesis. So the hit number 4 is really the management of patients with proteinuric kidney disease, with patients with a chronic kidney disease, and to try to delay the progression of kidney failure. And then the second strategy is really to target the inciting event for patients with IgA nephropathy, and that's really targeting the Gd-IgA1. And finally, we do want to get rid of the inflammation that happens in IgA nephropathy, and that is going to be the third strategy, which is anti-inflammatory treatment. So let's begin with anti-proteinuric therapy and how we manage patients with IgA nephropathy as a CKD condition. And so in this respect, we have 3 drugs that we have in our armamentarium, and that's the use of ACE inhibitors and ARB, RAS blockade, the use of SGLT2 inhibitors, and of course endothelin antagonists. I'm not going to spend any time on the ACE and the ARB because I think that's familiar with everyone, it's well established. But let's talk about SGLT2 inhibitors. Suceena has demonstrated that the benefits of SGLT2 inhibitors in IgA nephropathy was based on subgroup analysis of 2 large trials, mainly the DAPA-CKD as well as the EMPA-Kidney study. What I want to highlight to you is that despite the fact that its benefit in IgA nephropathy, the eGFR decline with the use of SGLT2 inhibitor was in the order of -3.5, and we are still not hitting the target of less than 1 ml per minute. So therefore, with ACE-ARB, and this studies all patients have ACE-ARB, and they add on SGLT2 inhibitor, we are still not meeting the target, and we still get a significant risk of getting kidney failure in our patients. And then we move on to the ETA receptor antagonist. So endothelin-1 basically binds to ETA and ETB receptor, and they are responsible for a lot of the vascular homeostasis in the kidneys. Now, to simplify this, binding of ET1 into endothelin-1 to ETA is bad. It causes vasoconstriction. It basically causes fibrosis. Whereas binding of endothelin-1 to ETB receptor is good. It causes natriuresis and vasodilatation. Now, in kidney diseases, and including IgA nephropathy, an overexpression of ETA, meaning an overbinding of ETA over ETB, is found to be the cause of renal damage, and blocking ETA therefore shifts the balance up and perhaps will improve fibrosis as well as kidney disease progression. You have heard that sparsentan was based on the phase 3 PROTECT study, received full approval. Sparsentan is a little bit different. It's what, as Suceena has mentioned, is a DARA, it's a dual endothelin A receptor antagonist, as well as a RAS blocker, ARB. So this is a combination. And so this was not a placebo-controlled trial. They basically investigated the use of sparsentan against irbesartan, and you see that there is significant reduction in proteinuria with the sparsentan group, and there was preservation of the eGFR, but again, note that the eGFR decline is again still less than 1 ml per minute. And then there is a phase 3 study called the ALIGN study that is looking at atrasentan. Atrasentan is different from sparsentan. It is a more potent and it's a more specific endothelin A antagonist. It has, it's basically, it is it's placebo-controlled, and the patients are randomized 1-to-1. And the interim analysis of the 9 months proteinuria data have been announced, and the company is now filing for accelerated approval based on this analysis. And you know that they have demonstrated that the patients who were randomized to atrasentan showed a significant reduction of proteinuria of more than 38% compared to placebo. And then we are now awaiting for the eGFR data, which is expected to be at the end of next year. So shifting gear, we're now going to move from CKD management, and we're going to look at targeting essentially the inciting event for IgA nephropathy, and that is to try to reduce Gd-IgA1. And in this regard, we have 2 main agents. One agent is NephCON, as mentioned by Suceena, and the other agent is basically targeting the anti-APRO as well as the BAFF pathway. So if we look at B-cell biology, we have heard from Dr. Hitoshi that rituximab has not been shown to work, and that's because rituximab tends to work among the B cells. And then there is this group which is the long-acting, long-surviving plasma cells, as well as the long-surviving B cells that are not really affected by the anti-CD20 therapy. And so essentially BAFF and anti-APRO will target this group, and the main important mechanism of this group of drug is that the anti-BAFF and anti-APRO sort of blocks the class switching from IgG to IgA. So it does make sense that we are going to be able to sort of reduce Gd-IgA1 by blocking this class switching, and at the same time it blocks the production of the autoantibodies, so it tends to hit your hit 1 and hit 2. So this is a summary of the number of drugs that acts on the B cells, and what we are looking at is this group in green and orange. So the difference is that there is drugs that just act specifically on the anti-APRO pathway, on the APRO pathway. There is drugs that's acting specifically on the BAFF pathway, and there's drugs that acts on both. So, and the important, as you have heard from Dr. Hitoshi, is the mucosal link that results in the production of Gd-IgA1. We do see that there is an activation of BAFF and APRO resulting in the production of Gd-IgA1, and so therefore, and that results in the pathogenesis of IgA nephropathy. So targeting the mucosal APRO does make sense. And this came about from the NephCON study. Now, the NephCON study, you have heard the data, but what I want to highlight here is that it's actually a 2-part study where patients were randomized to receive 9 months of NephCON or placebo. Then they were taken off the drug for 3 months and to show an effect, whether there's a sustained effect of the drug up to 12 months. Then the patients were observed for another year without the drug to look at the effect. And what NephCON, the study have shown is that you do get a reduction that is persistent up to the 1-year mark, but after that, there is a rebound in the proteinuria, suggesting that this patient, that this drug probably needs to be redosed, and that you can't just stop at 9 months. The other thing I want to highlight is that the patients who received NephCON had a significant improvement in the eGFR at the beginning of the drug, when they were receiving the drug. Now, NephCON was being marketed as a drug that has very minimum absorption of corticosteroids. It is still a corticosteroid and therefore have a much reduced side effects of corticosteroids. But the fact that if you have an increase in eGFR after you've been dosed with NephCON suggests that there is an anti-inflammatory condition and suggesting that there might actually be a significant absorption of systemic corticosteroid effects. So, and anecdotally, I have started patients on NephCON. They do get steroid side effects. It's not no side effects, there is still some side effects, and so that is something that must be taken into consideration. And NephCON costs 10,000 Singapore dollars per month for 9 months, so it's a really expensive drug to use. Then we move on to the anti-APRIL. So sibeprenlimab is the first anti-APRIL that was published in a phase 2 study. This was a dose-finding study, and they basically randomized patients to 3 different doses of sibeprenlimab. It is a specific anti-APRIL, and what they have shown, just to summarize with the charts on the right, is that it results in the decrease of Gd-IgA1. So yes, it's working at the point of the inciting event of IgA nephropathy. It results in the reduction in the proteinuria at 9 months, and they did show some eGFR effect, but again, that was too early to be interpreted. But this has now moved into a phase 3 visionary study, and again, the company has just announced the interim analysis. The exact details of the interim analysis has not been announced as per FDA requirements, but it shows that at the 9 months, proteinuria reduction in the phase 3 study was a significant benefit, and I'm sure that you would hear of the presentation at the next international meeting. So this is to summarize. This is a very busy space for IgA nephropathy. There's a lot of anti-APRIL and BAFF studies are in place. There are at least 4 studies. A 5th one that is on telitacicept that's actually being conducted only in China, and I'm not including that because that's not an international study. But if we have just anti-APRIL specific blockade, we had the phase 3 visionary study, which is sibeprenlimab, and there is an ongoing beyond study, which is zikakibart. And then there's the dual APRIL-BAFF blockade study, and that's the Origin 3 study. That's a phase 3 study is ongoing, and the RAINIER study, which is povetacicept, that is just starting up. Now the differences is whether they are just blocking APRIL on its own, whether they are blocking both APRIL and BAFF, and the frequency of administration. All 4 studies are now subcutaneous. Visionary and RAINIER study are both given monthly. Origin is given every single week, and zikakibart is given every 2 weeks. Now, do we know whether that blocking both BAFF and APRIL gives you a lot more potent efficacy? That is something that is not being studied, and I don't think that we're going to see that study coming up. But all these 4 trials will provide us with data on the degree of proteinuria reduction, on the eGFR decline, and we would have to make some interpretation on our own. And finally, the anti-inflammatory approaches. After we have targeted the Gd-IgA1, we still need to get rid of inflammation. And the testing study was what has been mentioned, that's corticosteroids. It basically gives us some confirmation of the benefits of corticosteroids. Now, the testing study started with a full dose, and that included about 260 odd patients. The authors have shown that there was benefits. However, the trial was stopped because of a significant number of infection-related deaths, and so they have moved on subsequently because of the benefits from the full dose to move into a low-dose cohort where they were giving corticosteroids in the form of methylprednisolone at half the dose, and patients were then also required to take Bactrim prophylaxis, and this recruited about 241. To summarize, the testing study shows the benefits of corticosteroids both in the full dose as well in the reduced dose in the low dose testing, and the side effects in the low dose testing was significantly lower than those that are seen in the full dose. However, I do want to highlight that the graph separation for the full dose is significantly bigger compared to those in the reduced dose, where there is still benefit, but you see a much smaller graft separation. And so again, that will be something that you have to take back when you interpret these results. And then, of course, finally, we talk about complements. As mentioned, the alternative pathway and the lectin pathway are important in IgA nephropathy. These are the trials that now I'm going to summarize that are involved in this study. Iptacopan, I'm just going to skip this. This has just gotten accelerated approval based on the fact that they have shown proteinuria reduction of about 38% at 9 months. What is ongoing now is revolizumab. This is a terminal complement pathway inhibitor. It has shown benefits in the phase 2, and the phase 3 now is being activated, and then we're actually going to hold the first APAC investigators meeting next week. So to summarize, IgA nephropathy is really like the battle for Middle Earth. It's like the Lord of the Rings. How many of you have watched the movie? Okay, this reflects your age because it's really 20 years ago. So we have, when you have a battle, the first thing you want to do is to provide a defense for your own castle, and that's the protection for Helm's Deep. And what do we have there? That's anti-proteinuric therapy, CKD therapy that's protecting your own ground. We have the ACE-ARB, which is very familiar. We have SGLT2 inhibitors, which are now quite well established. And now we're looking forward to data from the endothelial antagonists. We have sparsentan, and hopefully from atrasentan, we are now seeing a positive result. So these should still form the defense mechanism for you guys. Then, to win the war, the next thing you're going to do is to kill the general, and that's going to be the Eye of Sauron, right? So you have to bring it down, the Gd-IgA1. So what do we have? We have to destroy the ring. So we have the anti-APRIL or the dual anti-APRIL blockade. These are going to be key drugs that's coming up because they don't use corticosteroids. They have considered to be low side effects. And then we have targeted release budesonide. And I suspect once the anti-APRIL drugs comes on board, budesonide, NephCON is really going to fall out of favor because of the cost and still significant side effects. While waiting for the general to be killed, you need to get rid of the troops that are attacking you, and that's basically the inflammation. You need to fight back the inflammatory damage. So what do we have? We are going to have complement inhibitors. Iptacopan has gotten accelerated approval, and therefore that's going to be one drug. And of course, you have systemic corticosteroids, something that you're not going to want to do because of its significant side effect. So we have managed to target hit 1 and hit 4. So what happens to hit 2, the autoantibody, which is Saruman? And what you're going to do with hit 3, which is basically your immune complex, the huge elephants that's trying to win the war. Are there going to be drugs? I will tell you that there are drugs that are now being planned. There is a particular novel treatment that is going to reduce immune complex, but because of non-disclosure agreement, I'm not able to tell that. You want to hear more about it, the trial is going to come up. You will have to invite me next year. So with that, I thank you for your kind attention.